Today we are going to continue the study on the differential diagnosis and treatment of acute appendicitis. As a clinical misdiagnosis rate of acute appendicitis is high, a differential diagnosis should be carried out for acute appendicitis versus lots of other diseases, which many fall into the following tips. Differential diagnosis versus acute abdominal diseases in the internal medicine. Acute mesenteric lymphadenitis. It is a common disease for children and often occurs after the upper respiratory infection. Because of the general swelling of the lymphnode mesostenes, the terminal ileum is particularly evident, and the clinical manifestations on the child patient may be pain and tenderness in the right upper quadrant similar to acute appendicitis. However, the abdominal tenderness of this disease is more general and sometimes the swollen lymph gland can be reached. Differential diagnosis versus acute abdominal disease in gynecology and obstetrics. Right tuber pregnancy. After an internal rupture in such a pregnancy, the intra-abdominal hemorrhage would irritate the parietal peritoneum in the right lower quadrant, which could be clinical manifestation of acute appendicitis. But the tube pregnancy generally has a meninopsis history and an early pregnancy history. Through gynecological examinations, intravaginal blood, a slight large uterus, accompanied by tenderness, swelling at the nexa on the right and bloody fluid in the puncture of posterior fornix can be observed. Tossing of ovarian cyst. After the tossing of the pedicle cyst on the right, the symptoms of disturbance of cyst blood circulation, necrosis, and hemorrhagic effusion present, resulting in inflammation in the right abdomen similar with appendicitis. The B-scan ultrasonography of the abdomen can prove the existence of a cystic mass in the right lower quadrant. Picture of ovarian follicle. It often occurs in a married young woman and attacks 2 weeks after the menstruation, where a pain in the right lower quadrant may occur due to intra-abdominal hemorrhage, and the bloody exudate can be extracted through the diagnostic abdominal paracentesis. Differential diagnosis versus acute abdominal diseases in the surgery. Acute gastroduodenal ulcer perforation. After perforation due to the anabrosis, some gastric contents gets into the right fossa iliaca through the right paracolic sulci, leading to an acute inflammation in the right lower quadrant. However, this disease has a history of chronic anabrosis, is generally induced by gonadotropin before the attack, and could occur all of a sudden, accompanied by an acute abdominal pain. During the physical examination, the abdominal wall has become board-like rigidity. Signs of peritoneal irritation are most prominent below the xiphoid. A few gas can be seen through the X-ray examination of the abdomen, and the liquid in the upper gastrointestinal tract can be extracted through the diagnostic abdominal paracentesis. Acute cholecystitis and cholecystitis Acute cholecystitis sometimes also requires a differential diagnosis versus a high-position appendicitis. Acute cholecystitis often have a history of being attacked by the biliary colic and accompanied by the radiating pain in the right chest or back. Cholecystitis has the characteristics of a shifting pain in the right lower quadrant and gallbladder enlargement, and some sort of calculus can be displayed through the B-scan ultrasonography of the abdomen. Acute mucous diverticulum. The mucous diverticulum is a congenital malformation and many at the end of the ileum, close to the appendix, and in the case of an acute inflammation, the symptoms are similar to those of an appendicitis, for which a differential diagnosis would be difficult before an operation. Right ureterococcyly. The downward movement of uterococcyly may lead to a pain in the right lower quadrant and sometimes be confused with appendicitis. But under the attack of the ureterococcyly, the patient would suffer an unbearable intense pain. The pain radiates to the vulva and the inner thin along the ureter. The tenderness in the right lower quadrant and the muscular tension will not be obvious in the abdomen examination. Calculus can be found in the urinary system through the X-ray examination, and a large amount of red blood cells will be identified in the routine urine test. Next, we are going to discuss the treatment of acute appendicitis, the therapeutic principle first. For the simple acute appendicitis, the non-operative treatment combining the traditional Chinese and Western medicine may be practiced where the condition alone. Nevertheless, close observations must be carried out, and an operation should be scheduled in time when the condition has some development. In principle, an emergency operation should be immediately performed for purulent and perforation appendicitis to exercise to appendix with pathologic changes, and an active post-operative anti-inflammation treatment is required to prevent complications. If the disease has lasted for a few days and is accompanied by an appendicitis, with inflammatory mass conservative treatment may be carried out for the time being to promote the inflammatory resorption as soon as possible. And if the symptoms still exist 3 to 6 months later, the appendectomy may be considered. If the abscess enlarges and may rupture during the conservative treatment, an emergency abscess drainage should be carried out. In principle, an emergency operation should be made for acute appendicitis of old people, children, and pregnant women in the same way as for adults. Non-operative treatment is mainly applicable to simple acute appendicitis or elderly patients who can stand the anesthesia and operation. The treatment includes rest in bed, diet control, appropriate fluid infusion, and expectant treatment. Broad-spectrum antibiotics and anti-anaerobics agents should be used. An operation is preferred for the treatment of acute appendicitis, including various types of acute appendicitis, recurrent chronic appendicitis, appendiceal abscess, still with symptoms 3 to 6 months after the conservative treatment, or patients to whom the non-operative treatment has failed. The operation methods include the conventional appendicectomy and appendicectomy via peritoneal scope. The post-operative management of acute appendicitis includes to continue the anti-infection symptomatic and supportive treatment, including venous transfusion, pain relief, sedation, anti-infection treatment. The drainage tube embedded, if any, should be removed in time. Stitches in the incisional wound should be taken out as scheduled, and cures should be taken to prevent complications. Postoperative complications of acute appendicitis are closely related to the pathologic pattern of the appendix and operation time. Incision complication, mainly the infection of incisional wound. It often occurs 4 to 7 days after the operation. And the main manifestation include a throbbing pain at the incisional wound, local inflammation accompanied by tenderness, and a rise in the temperature again. At the moment, the suture should be immediately opened for drainage. Pelvic abscess if the resorption of the celiac pus is incomplete after the appendicectomy. For perforating appendicitis, remnant abscess may be placed in different positions of the abdomen, mostly pelvic abscess. It often occurs 7 to 10 days after the operation, and the manifestation include a rise in the temperature again, increase of the defection frequency, tenesmus, and a positive result in the dental rectal examination. Incision and drainage should be carried out when the anti-infection treatment has failed. Adhesive intestinal obstruction. The chances of intestinal adhesion after the appendicectomy are high. According to statistics, after the excision of acute appendicitis, the incidence rate of adhesive intestinal obstruction is about 2%, for which comprehensive conservative treatment is generally the first approach. And an operation should be followed when the treatment is effective. Fistula. It occurs at the appendiceal stump not properly treated, or may be induced by a brutal damage to the sacrum or ileum during the operation. And the main manifestations are the prolonged condition of the incisional wound infection and the infusion of feces and gas. Next, we are going to talk about special type of appendicitis. Acute appendicitis in children. It is not rare in clinical cases, and is developed due to the hypoplasia of children's omental medulla and their limited inflammation, localization capability, and during medical consultations, about 18% children patients also suffer different levels of the purulent peritonitis. The clinical manifestations of these patients are not typical. The prominent manifestation is the gastrointestinal reaction, and sometimes frequent vomiting is the primary symptom. Additionally, as children are not cooperative in physical examination, the presence and the range of tenderness in the abdomen are difficult to determine. And to get accurate results, the cooperation of the child patient and the parents is needed so as to examine carefully. Once the diagnosis is conferred, the appendicectomy should be carried out immediately, and care should be taken to strengthen the preoperative preparations and the postoperative treatment. Acute appendicitis in older adults. Older adults often have various diseases in the main organs, such as coronary heart disease. The death rate of acute appendicitis is high and increases with the growth of age. For old people attacked by acute appendicitis, the appendix of about 30% of the patients has been perforated when they come to hospital because of the no resistance, thinning appendix wall, and angiosclerosis. Moreover, as the augmented measure has shrunk, the localization of inflammation would be difficult after the perforation, and the chances of accompanying purulent peritonitis are high. The clinical manifestations of those patients are not typical, and because of the poor responsiveness and obscure abdominal pain of all the patients, they usually don't show the feature of the shifting abdominal pain. Since the abdominal muscle has shrunk, the peritoneal irritation sign is not apparent. Even if the appendix has perforated, and the mass may occur in the right lower quadrant after the formation of periappendiceal abscess. Except for the conservative operative treatment for simple appendicitis, under close observations, the appendicectomy must be carried out for all other types of acute appendicitis. In older adults, and similarly, care shall be taken to strengthen the preoperative preparation and the postoperative treatment to ensure the operation safety. Acute appendicitis in gestation period, due to the physiological characteristic of pregnant women, the risk of appendicitis is higher than common adults. With the enlargement of the uterus, the position of the cecum and appendix would change. The tip of the appendix would rotate counterclockwise while the appendix moves upward, and sometimes the cecum and appendix would move outward and backward. In the gestation period, the inflammation would develop rapidly in the case of hemorrhage of a pelvic organ, and the chances of appendix perforation after the inflammation are high. As the augmented measures is pushed to the other side, it would be difficult to localize the inflammation, and the chance of accompanying the general peritonitis is increased. For acute appendicitis in the gestation period, considering the safety of pregnant women, the appendicectomy shall in principle be carried out for patients with a gestation period less than 3 months, same as in the non-gestation period. For appendicitis in the second trimester of pregnancy, operative treatment is still the best option for patients with serious symptoms. In the third trimester of pregnancy, care should be taken to prevent miscarriage and premature delivery. That's all for today. After the class, you should carefully look up and review the relevant knowledge.